Hello and welcome to the newest edition of Pro Pharma Talks. My name is Alex Fernandez. Alongside me is always Dr. Craig Stern. And our topic for today is rebates. Now, the reason why we're talking about rebates is there's been a lot of discussion going on in the news and elsewhere about these high cost of drugs, right?
Right.
And so rebates are coming up as a main villain in that.
Right.
Can you explain to us just briefly about why that is?
Yeah. The cost of drugs has gone from probably somewhere in the range of $135 for a branded prescription a month that was true in the last, say, 7 years,
Right.
to now where branded drugs are costing over $1,500 a dose. And people are, that's the issues, a lot of drivers in that topic, but one of the issues that comes up is rebates, where people are saying that, or manufacturers are saying, the list price of the drug is not really the cost of the drug.
Okay.
We have to give rebates or coupons or discounts, whatever you want to call them, and one of the villains that they bring up is pharmacy benefit managers. So we have kind of this fight going on between different entities over.
You did it.
Yeah, your fault.
Yeah.
And so that's why we thought it was important that we talk about it.
Yeah, and let's go into more detail about it. I mean, you mentioned manufacturers are saying they're bumping up the price so that they can meet their bottom line. Is that what it is?
No, it's more of, it's like a car. You put out a list price for the car.
MSRP.
MSRP,
Yeah,
yeah.
yeah.
But people don't pay that, right?
Right.
Because you come in and they negotiate with you and they give you discounts and all the rest. So whatever was the list price looks good with regard to someone looking at the car and saying, oh, that's an expensive car or a cheaper car. But what you actually pay is something less. And that's where this whole issue is coming about, because then people ask the obvious question, and that is, well, who's getting these discounts and where does the money go? Because if I'm the patient, it doesn't come to me.
Right.
If I'm a payer, the payer is saying, well, wait a minute, it doesn't come to me either. And so who is it that's getting these discounts? How are they handling it? And
Right.
that's where this whole subject is.
Right, because as a customer, you hear rebates and you're saying, "Ooh, I'm gonna buy this, and then I'm gonna get some money back for it."
Right.
And that doesn't necessarily happen.
No, it doesn't.
Somebody's getting that money. So how do we
Right.
find out who does?
Well, if you listen to the argument, now we're not promoting here who's right or wrong, because to be honest, everybody's wrong.
Right.
Everybody has their hand in the till and they're busy taking something out of the till in order to deal with it. Certainly not on the provider's side, unless
Right.
providers are delivering drugs and then they've set their own list price.
We're taking the more journalistic approach, where we're saying just the facts.
Yeah. Is the following. A drug company identifies what the cost of the drug is going to be. Now, in a general sense, nobody knows where that price comes from.
Right.
You know it costs something in order to do research and development on the drug. You know that there's some cost with regard to the delivery of that drug, the packaging of that drug. Nobody knows exactly what that is.
And
That's a well-kept
advertising.
secret, right? And advertising, it's a well-kept secret.
Right.
But then, having said that, then the question is they want to put it out to the marketplace. And like most other products, if you sell one, it costs a lot more than if you sell 100. So over time, the issue has been, well, okay, how much do I get if I can get enough quantity in order to lower the price? And that's always been true of discounts and one-off with 12 and all of these different things. In the drug industry, they're known as rebates. Unfortunately, the contracts between pharmaceutical manufacturers and pharmacy benefit managers, or pharmaceutical manufacturers and health plans, if they deal directly, are secret. Nobody knows what's in those contracts. Now, we as auditors have seen them, but that's not something you stand on a street corner and tell everybody what the number is.
Yeah.
What you do know is that the Manufacturer has identified a particular list price and people get a discount. Well, how do they get a discount? If you put the drug on the formulary, so a different insurers are tied to finding the best drugs for the best price.
Right.
Fine. So if you put the drug on the formulary, you get one fee, you get one price. Now, if you put it in a lower cost tier, meaning the person has to pay a lower copay, then that's something that helps motivate people, motivate doctors to prescribe the drug. And as a result of that, it moves market share. In moving market share, that's the incentive that helps to get lower and lower costs.
Right, because more people know about it, more providers know about it, they want to.
Exactly.
And that's one way to meet this manufacturer's bottom line as far as how do you get the lowest costs? Well, how are you going to move the most product to get to that bottom line?
Exactly.
Right.
Then manufacturers have a fundamental concern. On one level, they're paying for a lot of advertising, so you see it on television, you see it in magazines, you see it on the internet, where they are advertising a particular drug.
Right.
And the goal, obviously, is for people to know about it. If they know about it, then they are going to ask their doctor about it. And if they ask their doctor about it, then they have a greater chance of it being prescribed. Right. So they are advertising. They also have drug representatives going out to manufacturers in order to promote them, in order to tell people about what they value, which is an important issue because people want to know, I have a particular disease, for example, like diabetes. What is it that I'm going to get to treat it? And there's a bunch of different drugs out there. So each one of the manufacturers is trying to tell people about their drug, what the benefits are, etc. That's common, it's standard, it's a common way of marketing what goes on.
Right.
The question then is that they have done that, the manufacturers done that. Now, what has the health plan or the PBM done in order to help to move even more market share?
Mm-hmm.
The way that they move more market share is to say, well, we're going to put it on the formulary, but we're going to put it at a lower tier or a lower copay, so the people, when they get the prescription, won't pay as much for that drug as they would for another drug in that same category.
Right.
In doing so, they're helping to move the product. So now we have an incentive-based system predicated on being on the formulary, and we have a series of rebates or discounts that are available for people to be able to get some benefit.
And this is strictly the relationship between manufacturer and PBM as far as this scenario.
And or manufacturer and health plan if they're dealing directly without people.
And then this is how rebates get applied based on the market share.
Correct.
Okay.
Now the other issue though is, number one, what drugs are rebated, and in this case, brand drugs are rebated because they only come from one manufacturer. Or maybe they're co-branded with more than one, but not a lot of them. You don't rebate on generics because generics come from half a dozen or more different manufacturers. Mm-hmm. So there's no rebate to give because they're dealing directly on price.
Right.
Okay.
So it has to be strictly brand.
Exactly.
Okay.
So now we have a branded product that we're trying to move, that we're trying to get more incentive, that we have a system of providing discounts or rebates in order to get it. Okay. The issue though then becomes that people look at this and say, well, I'd like to see that it comes directly to the patient when they pick up the prescription. It's so-called point of sale or point of care.
Right.
Medicare, when Medicare was established for drugs, Medicare Part D, one of the elements was that all of these discounts, including rebates, would flow to the individual patient. So you take whatever the drug cost, you discount it by the rebates, and therefore the patient was going to be paying a much lower base fee. The argument went in the industry and said, well, rebates aren't paid at point of sale. They're not paid when the person picks it up. So as a result of that, that can't be done. However, since Medicare Part D was started,
right,
now we're moving towards giving those at point of sale.
Yeah, because it makes sense.
It makes sense. CVS has said they're going to do it. Walgreens has talked about that they're going to do it. Optum or United Healthcare has talked about they're going to do it. So
Right.
in fact, there's a bunch of different groups in the pharmacy community that have said we're no longer going to have rebates. We're going to have some sort of discount for the patient. Now, does that mean all rebates go away?
No.
Or does that mean that the discounts are being passed along to the individual patient when they get it? That's unclear. All of the different arguments and how it's to be done are all being argued, whether it's in Washington or in the states right now, or even at the local pharmacies about
Right.
how it's supposed to be done. But there's also another argument called DIR, and we'll get to that in a minute.
Right. So just branching on what you had said, you had mentioned that the cycle goes like this. Manufacturer has a drug. They want to make sure to get that drug out to as many people as they can, or whoever needs it. I mean, I'm sorry, I'm not trying to pass it along. But anyways, manufacturer gets a drug. They have it at a pharmacy. Pharmacy gives that drug to the customer, and then the rebate gets applied to the PBM that adjudicated that claim, and they keep the profit at that point.
Well, part of that is unclear because all of this is a secret.
Exactly, of course.
Okay.
It has to do with contracts between manufacturer and PBM.
Yes, and also has to deal with contracts potentially and health plans that deal directly with the manufacturer. So there's multiple players. There's also a group called rebate aggregators where one large group gets rebates from a host of different PBMs, accumulates all of that, and gets rebates with the manufacturers, and then doles it out for each one of the PBMs. So there's multiple ways of doing this. The biggest rebate aggregator in the country is Express Scripts. But bottom line in all of this is that we're looking at a system that is a secret. Patients want to know that that is driving costs up. Their question, of course, is it driving it up so it's not affordable? Or is it just driving it up and somebody's keeping it? Does the health plan get to keep some? Does pharmaceutical manufacturers keep some? Do PBMs keep some? Who are all these people that are keeping? And that led to an argument. And I said before that Medicare had said one of our goals was to apply this at the point of sale where people were going to get their prescription.
Right.
Well, when the decision was made that no, rebates are not paid that way, they're paid quarterly, not at the point of sale, what that did was to set up something called direct and indirect rebates, which meant that any discount, if somebody got one free with 12, a pharmacy, then that discount needed to be passed along to the patient. If they got a 10% discount, that benefit needed to be passed along to the patient. Well, that started an argument between PBMs and pharmacies over what is included. It was already included in law within Medicare, but pharmacies said no, the PBMs are taking too much and they're including things that are not in the formula. PBMs said no, we want to make sure that the drug is being done right, and so it's being taken care of. And what that did was to add yet another fight, not just between pharmaceutical manufacturers and PBMs, but now PBMs and pharmacies, retail pharmacies. So we had yet another argument. That argument is going on. It's going on in the states. It's going on in the federal government. And the argument is to remove the DIR by ensuring the fact that rebates are at point of sale and no longer an issue where everybody's arguing about contracts where nobody knows how much is kept, nobody knows how much the total is, nobody knows how much is going to be given to the health plan or to the patient or otherwise, and as a result, everybody's in an argument about what happens to these costs. It doesn't take the drug cost from here to zero, and it doesn't take it from here to affordable, but unfortunately everybody's involved. The contracts are all secret, So as a result of that, everybody's fighting over what that means.
I think the big disconnect here is who was the rebate program made for?
Well, if you go back,
Right.
the issue was that manufacturers were putting their representatives out. They were doing advertising, and so they didn't pay rebates because they were paying for all this money to get their drug recognized.
Of course.
Okay? When formularies came in, they said, okay, we will give a certain rebate to have our drug on the formulary. When tiers came in, meaning where people
But they said they would give that rebate. Give that rebate to who?
Oh, they
That's
give
the
that
disconnect.
rebate to the health plan. Okay.
See, there it is.
And so the health plans then got these additional rebates paid quarterly.
Mm-hmm.
And the argument was, and continues to be, that that helps to lower the cost of the benefit. Because the health plan is paid for the drugs as part of the premium that people pay. And then the rebates help to lower that cost so that they can keep the cost of those premiums low, which leads to yet another argument. And that is, if you remove the rebates, or you remove part of the rebates, then the cost of premiums for individuals is going to go up
Of course.
because health plans are not getting that money back in order to deal with it.
Yeah,
And of course,
when you put it that way, then it makes sense.
and then of course the other question is, how do people know that if the plan was getting a certain rebate and the rebate is being passed on to the individual, how do you know there's parity? Was the same amount of money that was paid in rebate also the same amount of money that was paid out in lower costs to individuals, or is there some sort of a disconnect there? How much is kept here? How much is kept there? Certainly certain amounts are kept based on work that people have to do, but it's not huge.
Right.
It's a fee that people get because they have to do the work to reconcile the amounts and things like that. It's kind of like an accounting fee for paying for these different fees. Well, at the end of the day, what we have is we have a very confusing system because everyone doesn't know what the amount is. They don't know what the cost should be. They don't know who's keeping it. They don't know whether that would lower their individual costs, they, the patient. And clearly the health plan is saying, we expect a certain amount of money in order to help us to lower our costs. All of this is part of the fundamental argument because these things are kept a secret. Now, to be fair, if you buy a suit, if you go to a store and you buy a suit, you don't know how much it really costs the individual to make that suit.
Right.
You know that they had material, you know there was workmanship, you know there was that, but you don't know exactly how much it was. And certainly there is some cost to shipping and delivering and merchandising and retail and all of that. And people don't really know what that cost is. They don't know what the cost is. For example, you buy a pair of tennis shoes, you don't know what the actual cost is of the tennis shoe versus what you bought. There's a lot of talk about that. You know, the shoe manufacturers got $2.50 and they're selling it for $150. Clearly there's a difference. So it's not that the drug industry is entirely different here. It's that the costs keep rising and rising and rising, and it's come to a point where there's a difference between how much it costs and whether it's affordable.
Right. And I think a big part of this is how the system keeps changing. There's new players involved. There's always been a manufacturer. There's always been a pharmacy. There's always been a health plan, and then you got PBMs, and then you got different sellers in between. You got rebate aggregators. You got all these other players involved in the cycle. Everybody wants a piece of the pie too.
Well, when historically, when the manufacturers were putting out money and the rebates first came up, the original intention was to give it to the doctors because the doctors were the one that was prescribing.
Right.
Then the argument was, well, no, we won't give it
to be a doctor.
When it was lucrative to be a doctor. And then the argument came, well, the doctor isn't buying it. The insurance company is buying it. The health plan is buying it. So now they should get the rebate of what goes on. Then the middlemen, the pharmacy benefit managers, came in and said, fine, we'll do the negotiation, we'll deal with that. And then the argument was, well, how much are you keeping? So how much does the PBM keep? How much does the health plan keep? The doctor was left out, the patient was left out, the pharmacies were left out. And now we have an issue where there was conflict between the payers, the middlemen, the pharmacy benefit managers, and then all the people who ostensibly are making the decisions. Physicians made the decision to prescribe. The patient received the drug, had to pay something, a share of what it was. And so there was this big disconnect of what goes on. And that's a very public argument about what people are doing, and yet people still don't know what these costs are.
Yeah, and it's a fair argument. Excuse me. It's a fair argument. I mean, at the end of the day, everybody's just trying to figure out what's going on with drug costs.
Yes.
And rebates came up as one of the many issues. There's plenty of them that come out, but rebates is one of them, and it just seems clouded. You know?
Well, it is clouded. It may not be more cloudy than other products, but other products in general, you have a choice. If you want to buy Prius, then you have to have the money to buy a Prius. If you want to buy a Mercedes, you have to have the money to buy a Mercedes, but you have a choice. They still get you from A to B, but you have a choice of what to do. In the case of drugs, frequently they've been presented where there is no choice. So in that regard, this argument about it costs this but it's not affordable doesn't offer the opportunity to argue, and clearly pharmacists are there, they're in the center of it to be able to say, well, there are multiple drugs in this category, they have different prices, there are alternatives to those drugs, maybe some are generic, maybe some are a lower cost, what goes on. And then there may be even other alternatives with regard to drugs in the same category that have a lower cost. So there is an opportunity for this to go on, but as costs begin to rise to just extraordinary prices, that argument gets worse and worse because the spread between what it costs and whether you can afford it is just so big.
Right. Well, let's move on because we want to find out what's going to happen to rebates. They're talking about it now. It's probably going to go to the White House if it hasn't yet. But they're going to talk about, are rebates going to go away, or are they just going to be moved to some other type of cost to the patient or the insurer?
Well, if anybody says they know right now, they're wrong because nobody knows. Congress has certain ideas, states have certain ideas, pharmacies have certain ideas, PBMs have certain ideas, health plans have certain ideas. So at the end of the day, right now, nobody knows what's going to happen.
Whoever has the strongest lobby.
Whoever has the strongest lobby, or frankly, if the people rise up more than they are, identifying that they can't afford it, then there's going to be even greater issues. At the end of the day, though, we don't know what is going to happen, but it appears that irregardless of what the decision is, there will be more transparency. Does that mean you'll know exactly how much the drug costs or otherwise? No, you won't. Does it mean that you'll have a better idea of what the costs are, what the middleman fees are, about who pays it, and whether more and more of that is being transferred to the patient? Probably. But if you were to say, well, you know, what's going to happen and how are we going to do it, nobody knows for sure. It is just still very much of an argument where everybody's trying to figure out what's going to happen, and really no one knows. Perhaps over the next 6 months, everybody will know, and then there'll be arguments that it didn't go far enough, or it went too far, or it didn't, or whatever the argument is. But right now, nobody knows what's going to happen with rebates.
Well, I mean, hopefully it'll make its way to the presidential candidate stage. I mean, there's enough of them. I think there's like 30 of them.
24, I think.
That's just on one side. Yeah. So I mean, it's it's an ongoing discussion, and of course we will revisit once we have more information, of course. And if you have any questions, please feel free to direct message us or leave a comment below, or I guess you can leave a review on iTunes as well and talk about it there. So yeah, any last comments?
No, I think one thing that people need to realize as individuals is that a good deal of this is motivated by people saying enough is enough. So in that regard, people have power. Does it change everything? Do you get what you want? No, you don't. But if people don't write into their congressmen, their senators, if people don't say something, if people don't come up with alternatives, if people are asking their pharmacists for more information, their doctors for more information, then nothing is going to change. So power really is to the people, and the people have to realize you have to exercise it, but first you need to get information. Having information or arguing that this side doesn't understand or that side doesn't understand doesn't get us anywhere. There's a lot of science, there's a lot of background in this, and people have to learn it. Not that you become an expert in it, but that you stand up and say, you know, this is way too expensive. I need it to treat my condition, but I can't afford it. What are you going to do for me?
And that's one of the reasons why we started this, or why you even started it way before me. It's just getting that free information out there helps give you the information that you need in order to talk to your local congressman or some kind of way to promote change, right?
Yes.
Yeah. Yes. Thank you very much, Dr. Stern. I'd like to remind you to go to propharmaconsultants.com. We have a free information page called RxInfoX. We also have many articles written by Dr. Stern himself called Pharmacy Benefit News. And I think that's...
Well, there's a ticker on our RxInfoX that is a traveling ticker and identifies cost of drugs. So if you're interested, there's a lot of drugs out there. You can watch it and see what the cost of some of your drugs are and pick up on that actual price.
Hopefully your drug starts with an A or a Z. So anyways, we'll have a new video for you next week, and we'll see you then.